This PowerPoint is about the urinary system. Learning objectives are to do a nursing assessment of the urologic system, which of course includes the renal portion and a renal assessment, to review the anatomic structures, discuss the pathophysiology, as well as clinical manifestations. We need to know the subjective and objective symptoms, and then looking at the different components of the abnormal, so UTI, urinary tract infection, pyelonephritis, glomerular nephritis, and looking at diagnostic testing for all the disorders. So these questions, you may not know these at the beginning, but by the end you should know the answers to all these. What is the functional unit of the kidney? Write down your answer and we'll continue. What does dysuria mean? Is it blood in the urine, pain with urination, frequent urination, or scant urination? A patient who is taking ciprofloxacin should be advised to monitor for orange urine, take the medication on an empty stomach. Urine output should be at least 1,200 mLs a day. Take the medication with a full glass of water. Which information from a urinalysis should the nurse report to the healthcare provider? This is a select all that apply. Should they report trace protein, trace blood, pH of 6.2, or WBCs 20 to 26 per high-powered field? HPF is high-powered field. So first we're going to look at the anatomy of the urinary and renal systems. And when you look at this picture, please note the right kidney is just a little bit lower than the left kidney. Why is that? Think about the anatomy. What's right above the kidney? Think about the picture in your head of the 4 quadrants of the abdomen. And right above the right kidney is the liver. So the liver displaces the right kidney a little more inferiorly. Also on top of each kidney, you're going to note that there is the adrenal gland, which we'll address when we go over endocrine. Notice the inferior vena cava and where it goes into the kidneys and where it goes and continues on down. Note the aorta and where it goes into the kidneys and where it continues down. You'll notice the ureters coming from each kidney and going into the bladder. And you will notice a lot of musculature and some anatomic structures. The anatomic structures also help when we are looking for various internal structures. When we know where the iliac crest is, we know that slightly superior to it will be the kidneys. The kidneys are going to be assessed posteriorly or from the back. So looking at the kidneys posteriorly, you can see where the 12th rib lies. So thinking of that, we also have to think about any trauma that might occur to the person's back and how it would affect the kidneys. So see the costovertebral angle. And this is an anatomic landmark. So when you are going to check on the kidneys, number one, if you were going to palpate them, sometimes you can catch them in your hands. You would have to have the person lying supine and come in behind them underneath. when you want to check the kidneys, have the person either sit or stand, probably sitting, especially if you're checking for pyelonephritis, which we'll talk about later. And you're going to do what's called a kidney punch, which is not really a punch, and I'm not a fan of the name, but you're basically knocking lightly with your fist. It's going to sound like this on a desk. And just a little tap on a kidney that's inflamed will hurt. So tell the person if there's anything going on, it may be uncomfortable. Looking now at the kidney itself and the various structures, and I like this picture because you can see a lot of things going on in these structures. You can see where the renal artery is located, the location of the renal vein, and the lymph duct. You see the ureter coming out, and you can see just here above is the renal pelvis. You can see the medulla and the cortex and the fibrous capsule protecting the whole thing. The medulla is where all the nephrons are located. We're going to go into that in a few more slides. Well, no, I'm wrong. We're going into it right now. This is the nephron of the kidney. This is the functional unit of the kidney. There are 1 million nephrons in the kidney, in each kidney. So you, with 2 kidneys, have 2 million nephrons. If I sound excited, I am, because this is just a powerhouse. And think how small it must be if there's 1 million in each kidney. The nephron consists, and you can see them marked here, it consists of a glomerulus, and a glomerulus takes care of selective filtration. It's a network of capillaries within the Bowman's capsule. Next is the proximal tubule, and you can see that. It says it's convoluted because it's not straight, it's twisted. It reabsorbs about 80% of electrolytes, water, glucose, amino acids, bicarb, and it secretes hydrogen ions and creatinine. Down at the base here, you see down at the bottom, loop of Henle. Loop of Henle reabsorbs sodium and chloride in the ascending limb and water in the descending limb. And it's involved in concentration of the filtrate. Your loop of Henle is where the loop diuretics work. The distal tubule, you can see that on here, and the distal tubule secretes potassium, hydrogen, ammonia. It reabsorbs water. And in order to reabsorb water, it's regulated by ADH, antidiuretic hormone, and it regulates calcium and phosphorus by the parathyroid. And then you can see the collecting duct over on the right, and that reabsorbs water. ADH is required. So if any of the parts of this nephron are not working well, then things won't be reabsorbed or secreted or excreted. So 1 million of these, in order for someone to go into failure, renal failure, they will have lost about 90% of the functioning of the nephrons. So that's all, even the ones that are remaining. So imagine that is a lot of nephrons that are doing a lot of work. This one here is a YouTube. You can watch this on your own. I had to change the one that was there before, which I liked better, but this one is really good, and it does tell about how the nephron works. So we're going to move on to the next one, the urinary system. Urinary system consists of the kidneys, the ureter, the urinary bladder, and the urethra. One of the tests that you will have to evaluate is an X-ray called KUB, kidneys, ureters, bladder, KUB. So you may hear someone being sent for that, particularly if they're complaining about a kidney stone. You can see everything's numbered here, which I really like and I can appreciate. You can see number 1, really not going anywhere, but number 2 to the kidney, number 3 to the ureter, and then 4 also goes down and shows the ureters. 5 goes into the bladder, and 6 into urethra. Number 8, more into the renal vein, and then 9 is the vena cava, 10 the aorta, okay, and another portion of the aorta listed here, and then there's nothing pointing. The kidneys filter the blood to remove waste and produce urine. The ureters, the bladder, and the urethra are the urinary tract, and they're kind of a plumbing system, and they drain urine from the kidneys. They store it and release it during urination. This next one is right from DeWitt. So you're going to see the hormones listed here. We're going to pay more attention to the hormones in the next section that we go, or when we go into endocrine, but for right now, notice here erythropoietin. We just looked at that. It stimulates bone marrow to increased RBC production, and remember we said that when the kidney's not working well, erythropoietin is not manufactured. We can also see calcitrol, so that's active vitamin D. So again, when the kidney's not working well. Renin, affecting the regulation of the blood pressure. So again, when the kidney's not working well, renin will not regulate the blood pressure and it will go up. The kidneys regulate serum electrolytes, as we just saw earlier, by filtration and reabsorption. So it's all got to be working well. The kidneys eliminate waste by filtration. So about 1/4 of the body's blood at any one time is being filtered. The GFR, glomerular filtration rate, is the amount of blood filtered by the glomerulus in any given time. So it averages about 125 mLs per minute, 125 mLs per minute. The kidneys regulate fluid volume by filtration, reabsorption, and excretion. There's about 200 liters of liquid filtered in a 24-hour period. Think of that. That's a lot of filtering. Picture 200-liter bottles, and that's how much in one 24-hour period a good set of kidneys is filtering. And so that's 1.5 to 2 liters are excreted as urine, so that's all the waste products. Kidneys are regulated by blood pressure, by secreting the enzyme renin, as we just said on the previous slide. Kidneys increase RBC production by secreting erythropoietin. Kidneys metabolize vitamin D into an active form, and each nephron filters blood plasma through a semi-permeable glomerular membrane. So it's doing so much work. There's a lot of work. So now on to the assessment. Of course, any good assessment, we want to know their past medical history, including surgery. So past surgical history, we want to know allergies. We want to know what medications they're on. Remember that medications are almost all excreted through the urine or the kidneys. So the kidneys have to do a lot of work. So the more medications people take, the more work the kidneys do. And also keep in mind that some medications may be nephrotoxic. So you always need to look and see what's nephrotoxic and what are their renal lab values. We look at objective data, what we can see. Objective lab data for their whole body and for urinary. So urinary in particular, we want to look at their urine. When I worked for the urologist would hold the urine up and look at it, and it tells so much. The really fascinating thing about the body is it tells on itself. It says, I'm not doing so hot. I'm not putting out the right amount of concentration or solutes. I'm not doing the right thing. I'm not putting out enough urine. I'm putting out too much urine. So it does tell on itself. And things that are in the urine that shouldn't be are excreted, and it tells something's not working. So we want to do a basic urinalysis, a urine culture to see if there's any infection going on, IVP, intravenous pilogram, which includes contrast. Therefore, the big three: allergies to contrast, iodine, shellfish. Are you taking metformin? And what's the creatinine value? KUB, which does not, it's just an x-ray of that area, so you don't have to worry about any contrast. CAT scan, always find out if there is contrast involved, and remember, in NCLEX land it will say it in the question. Ultrasound, voiding cystourethrogram, and cystoscopy. These are some of the things that are going on. So one of our students this semester, and almost every semester, is going to urology. Actually, a couple of them are going to urology, and there's a lot going on in that department. Age-related, you know that NCLEX wants you to know age-related problems, and these all make sense when you think of what goes on with the aging process. So the kidney function begins to decline after age 45. Renal blood flow and the glomerular filtration rate decrease with each decade. So every 10 years, everything gets a little slower. The prostate gland hypertrophy, so that, of course, only in males. Bladder muscles weaken and lead to residual urine and urinary incontinence. The kidney is not able to concentrate urine as well, and because of this, a lot of people complain of going to the bathroom a lot in the middle of the night, so nocturia. You always want to ask how many times, and you always want to ask, what are you drinking before bed? And then the secretion of renin, aldosterone, and vitamin T declines. So you can see there, everything gets slower or declines. You have to consider that renin is involved in the regulation of blood pressure. Remember from anatomy and physiology, renin is released when the blood pressure is too low, so that the blood pressure will go up. Renin is secreted from the juxtalar glomerular kidney cells, and what these cells do are they sense changes within renal perfusion. So if we're not getting a lot of fluid, that means we need to release renin to cause some vasoconstriction. The macula densa in the kidneys also signals to release renin, and that causes changes in sodium delivery to the renal tubule. Renin activates that renin-angiotensin-aldosterone system, and what it does, it causes angiotensin, which is produced by the liver, to convert to or yield angiotensin 1, and angiotensin 1 converts to angiotensin 2, and that's caused by your angiotensin converting enzyme. So that's why the ACE inhibitor prevents that from happening. The ACE, I'm just going to say ACE. ACE in the capillaries of the lung is what causes that conversion. Now remember from anatomy and physiology, Angiotensin II is a strong vasoconstrictor, and it increases the secretion of ADH and aldosterone, and that causes the hypothalamus to activate thirst. Thirst is the earliest sign of dehydration, so now the person's going to drink water, hopefully, and replenish their fluid supply. And what that results in is increased blood pressure. Renin's primary function is to increase the blood pressure, and when the blood pressure is increased from too low, so hypotension, this leads to perfusion of the kidneys. So we've got hypotension triggering the release of renin and the conversion by ACE, vasoconstriction, increased blood pressure, perfusion of the kidneys. Whenever there's hypotension, you need to look and see what's the urine output, because they will be affected, because the blood's going to go to the heart and to the brain, and unfortunately not to the kidneys. So hypotension, especially long term, you're going to see decreased perfusion of the kidneys, and since I can't see it because I don't have x-ray eyes, I'm going to see this by looking at the urine output. And if this person has a Foley catheter, I can see it right in front. And the urine output decreased will be a darker color and way lower than I'm expecting. So I need to get that kidney perfused, give them some more fluids, and cause some vasoconstriction, and work that kidney so it's perfusing again. Remember that aldosterone causes reabsorption of sodium, and vitamin D increases the reabsorption of calcium and phosphorus. Bladder health. So Healthy People 2020 goals are comply with the treatment plans for hypertension, control diabetes. So our teaching has to do with increased water intake. Unless a person is on some sort of fluid restriction, they can drink a minimum of 2 to 2.5 liters of fluid per day. Water, not coffee, not iced tea, not soda, but water. And then empty the bladder sooner rather than later. Don't hold on to it. Nurses aren't famous for this, but many other people too. So make sure they're going. Exposure to toxins from delayed bladder emptying increases the risk of bladder cancer. So as we're going to see, one of the main causes of bladder cancer is cigarette smoking, but it's also not emptying the bladder in a timely manner. The bladder is capable of stretching beyond its normal capacity. It strains the sphincters, and this might contribute to incontinence in later life. So tell the people, empty their bladder, and you too. You need to control the blood pressure and maintain a normal glucose. And look at the medications that may have nephrotoxins. So some of these will include your NSAIDs over the counter, acetaminophen, and for a better list, look in DeWitt box 33-1, and that has a list of nephrotoxic drugs. When these drugs are taken, the fluid intake should increase to 3 to 3.5 liters per day to reduce the risk of kidney dysfunction. The fluid increase only if they're not on a fluid restriction, and always consider the risk. So make sure that they're not involved in that. The other thing too is some of the antibiotics that we give for UTI are going to involve a certain amount of urine output and a certain intake per day, just because some of them may cause crystalluria. Kidney functioning. So we will look at the BUN, Increase in either BUN or serum creatinine can mean kidney dysfunction. We'll look at KUB, kidney ureters bladder, especially for stones and other structural abnormalities. Urodynamic test to measure flow, and you can see that down in the bottom right-hand corner. And also look into WIT table 33-2 for other diagnostic tests for urologic disorders. Remember that NCLEX wants to know that you know what must be done prior to the test, what happens to the patient during the test, and what happens after. So you're teaching afterwards. So for example, do I need to have consent signed? Is there any special prep? Do they have to be MPO? Do they need to be medicated pre? And post, what kind of teaching should I do? What things may occur? So down in that bottom, that is urodynamic test, a uroflow, and what we do for the patient, we tell them to drink a given amount of water, and that will depend on the physician. They should not drink coffee or caffeinated beverages. They come to the office or the surgery center, wherever they're told to go, with a full bladder, and then they void into a special type of toilet that has an attachment that measures the flow. So hopefully it will look like this with a high peak, showing that they have a strong urine flow. Sometimes it's more looking like a little squiggly line, that they just don't have enough oomph, and that gives a good picture of why maybe they're retaining urine. You also see on their biopsies, we do bladder biopsies, which involves a cystoscope, and we also do transurethral ultrasound, and that would be for males, and we are looking for cancer of the prostate. So labs for kidney functioning, of course, urinalysis, the first one we think of. Always look at the color and try to obtain a first morning specimen. You might have to give the container to the patient with clear instructions on obtaining a clean catch. Of course, have them repeat back to you what the instructions are. Give them an instruction sheet with some pictures, because it's very important that this is not a contaminated specimen. First morning, because that's when we're going to see the greatest concentration of solutes. Make sure clean catch, and whether you are doing a sterile culture or anything, even a urinalysis, it's the nurse's job to preserve the sterility of the specimen. So make sure there's no contamination, and the patient should refrigerate the specimen if they have a later appointment, and refrigerate this specimen unless it can be sent directly to the lab. You want to send cultures and urine right to the lab, because it will avoid changes in the pH. Telling them how to do a clean catch is very important. We have more info on that in a few slides. For urine osmolality, normal is greater than 850 milliosmoles per kilogram. A person who is dehydrated or has chronic renal disease, those problems will affect the value. What would you expect to see? Low salt diets or diabetes insipidus will decrease the osmolality. Uric acid, we will look at that. It's the end product of protein metabolism, and that level will be elevated in renal failure. Creatinine clearance, this tells how well the kidneys can excrete creatinine. Normal is 15 to 25 milligrams per kilogram in 24 hours. So it would be elevated with decreased urine creatinine, and that shows decreased kidney function. So decreased urine creatinine. You see elevated serum creatinine, but a decreased urine creatinine, and this will show decreased kidney function. When you are doing a creatinine clearance, discard the first specimen. You might also be instructed to collect 5 mL of venous blood during the collection period. Instruct the patient to avoid vigorous exercise as well as drinking coffee and tea and eating meat. For cytology, you want the first morning specimen, and that goes to the lab within 1 hour. This slide shows the ureterovesical junction, and you can see in the back where the ureters come in, you can see where urine would empty into the bladder. Anybody who is going to urology, if you get in to see a cystoscopy, you will be able to see this quite well. For urinary tract infection, the urinary tract and the urethra are usually sterile, so they shouldn't have any bacteria. And there's several mechanisms that keep this area sterile, but it doesn't always work out. So you want to try to teach the patient to prevent UTIs, and we know that teaching from PN1 for females, make sure that they are wiping from front to back, change out of wet bathing suits, don't take bubble baths. Anything that interrupts the sterility can cause interruption of the pH. We want a lower pH to destroy bacteria. You want to completely empty the bladder. Remember that menopause increases vaginal pH. The kidneys filter a high volume of blood, and the blood contains bacteria. Bacteria can colonize and cause infection. So sometimes bacteria enters the urinary tract through the urethra, and the infection may ascend. UTIs, we know it's the most common bacterial infection in women, and at least 1/3 have developed a UTI before their middle 20s. And we know because of the anatomy that there's more risk. We know the number one pathogen is E. coli. We know that females have an increased risk of UTI during pregnancy, so teaching to pregnant women, especially then, but anytime. And catheter-acquired urinary tract infection, remember that from PN1. We also want to avoid hospital-acquired urinary tract infections. Upper versus lower, particularly we're talking about pyelonephritis, which is an inflammation of the upper urinary tract. So that would be the cause there, and of course lower would be the lower urinary tract, bladder, and urethra. Urinary tract infection symptoms usually relate to bladder storage or bladder emptying. So people will say they have painful urination, dysuria, frequent urination, urgency, which they have to go right now. They may have suprapubic discomfort or pressure. The urine may have visible blood or sediment. Blood in the urine is never normal. Never, 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 ever, ever. Blood in the urine is always a sign something is going on. So if you have a female who has her period, you might be told to obtain a straight cath because you don't want that blood in the urine. It's not a good sign. Nursing interventions, of course, collect the data, including vital signs. Make sure you're taking a temperature and counting respirations. And then health promotion, teaching, know your patients at risk. Here's some nursing interventions that we can do without a doctor's order. You might suggest cranberry juice as long as there's no allergies. Some physicians prefer cranberry tablets, but a lot of times they want to make sure it's a good grade of cranberry tablet as opposed to something they might get in the grocery store. Avoid caffeine. Caffeine is a bladder irritant, as is alcohol, and cause more frequent urination. Citrus juices as well are also irritating to the bladder. They can apply a heating pad, but be cautious for the elderly and always tell them to put the heating pad on low. Make sure they know to take all of the antibiotics even though they feel better. And include education on reporting worsening of symptoms. They should be getting better, not worse. If they have increased fever or fever and flank pain, they may be progressing to a pyelonephritis, and that needs to be addressed at once. I'm sure all of you have seen a urine dip. Note in that left-hand column, you need a watch with a second hand. You need to time each one. So if you're not wearing a watch to clinical, don't pull out your phone. You don't want that around urine. So make sure that you're wearing a watch with a second hand so you can time each segment, because glucose will show up in 30 seconds. The pH within a minute, as will blood. Leukocytes will show up in 2 minutes. When I'm looking at a urine dip, the urologist looked more at the nitrites because of bacteria that forms nitrites, and to them that was more indicative of a UTI. Protein in the urine is not normal, but there may be medications that cause a positive. We're going to look at pH in a few minutes because we need to know the normal pH, which is different from that of the blood. Blood in the urine, never, ever, ever, ever normal. Ketones. Ketones in the urine for diabetics who are now in diabetic ketoacidosis. There's no going back. And also for people on like the Atkins diet or the keto diet, they will show ketones, which means they're in ketosis. Glucose, a lot of times this is the first time we pick up on that the patient is diabetic because they're spilling sugar. Here's your normal findings. Note there is a wider range of pH for urine than that of the blood. pH 5 to 9, protein less than 20, glucose and ketones, hemoglobin, which is the blood, bilirubin. There should be none in the urine. Urobili might be a little bit. Nitrites should be negative. This is usually what the urologist said meant that there was a UTI. Note the specific gravity, 1.001 to 1.029, and WBCs less than 5, high-powered field. Blood in the urine is never normal. It should always be investigated. It may be a sign of a UTI, but it might also be a sign of bladder cancer. So it's always got to be investigated. Here we're going over what might influence or what might cause a high or low of any of those entities. So a high pH, and these are some of the things that might cause it. Low pH, and you see their ingestion of cranberries too much. Protein, due to stress, so maybe you all have protein in your urine. Also exercise, exposure to cold, glomerular nephritis, toxemia of pregnancy. Ketones should not be in the urine, but if they are, the person is already in diabetic ketoacidosis if they're diabetic. It could also be from fasting or fever or starvation or high protein diets. It may also be present in the post-anesthesia period. More results. Nitrates will be present due to nitrate-forming bacteria, so UTI. Leukocytes may also be indicative of bacterial infection, also stone formation, calculus formation. Specific gravity would be increased due to any of those, including dehydration. So specific gravity increased in dehydration, but decreased in overhydration. Also excessive IV fluid, and you would also see decreased specific gravity due to the kidney's inability to concentrate urine. Clean catch. Make sure you know how to do it. Start with washing your hands thoroughly, and of course you've identified the patient and checked the order. The patient should cleanse the meatus or the labia from front to back. They should start their stream. Then they should stop the stream and void into the container, making sure that not to contaminate it, so no fingers into the container. A clean catch urine, a lot of times for the elderly, maybe with decreased ability to use their hands, dexterity, they may not be able to hold the container, so you may have to come up with plan B, either a straight cath, which we'd probably like to avoid, or help them out during this. Of course, that's going to be uncomfortable for them too. Here are the colors of urine. So a deep yellow urine, all these things may affect the urine. The ones I really want you to look at, obviously, is the orange. We know pyridium. And sometimes you will notice a smoky urine from RBCs, and brown, nephrophorantine, and metronidazole. So brown urine, orange urine. If you're giving these medications, make sure to tell your patient, hey, the urine might turn orange or the urine might turn brown, and that's normal. Next one is a urine dip. You can look at that on your own. And then UTI. Some of the things I want to talk about here. Usually we give antibiotics. You can see the names here. Make sure you checked allergies. Usually UTIs are treated successfully with 3 days of antibiotic therapy. Fluoroquinolones have been a mainstay. We love fluoroquinolones. That's the fluoxetine, ciprofloxacin, levofloxacin. There's some others too that you may see, but they have many black box warnings and many side effects. So the FDA is now warning about increased risk of rupture or tears in the aorta when fluoroquinolones are used in patients at risk for aortic aneurysms. So you need to know their history. You need to know what their doctors are watching for. Patients with a history of blockage or known aneurysms should not take a fluoroquinolone. Even hypertension or certain genetic disorders that involve blood vessel changes. Fluoroquinolones have interactions with steroids. Fluoroquinolones may increase the risk of tendinitis and also Achilles tendon rupture. Fluoroquinolones may increase muscle weakness in patients with myasthenia gravis. And one more thing, fluoroquinolones have been known to contribute to C. diff diarrhea. So really be careful when this patient is on, or any patient is on, fluoroquinolones. Nephrophorantine may cause agranulocytosis, so remember the white blood cells, the agranulocytes, and that would mean too many of them, or thrombocytopenia, so look at their platelet level. Because it affects the white blood cells, report signs of infection. So any sore throat, anything like that. And these signs can occur up to 2 months after treatment. Make sure that the patient knows that the urine may turn brown or even a dark yellow. For trimethoprim, make sure you know it causes agranulocytosis, aplastic anemia, so watch that hemoglobin, leukopenia, so watch the white blood cells again and signs of infection, thrombocytopenia, hemolytic anemia, Stevens-Johnson syndrome, and pancreatitis. Urinary tract infection, make sure you know the diagnostics. Of course, looking at all the different things for that you need to know for IVP, for cystoscopy, UA, culture, and renal ultrasound. Always when you're looking on NCLEX and in real life too, think about your patient. What's going to cause the least amount of infection, so the least invasion? So we want like urinalysis or renal ultrasound. We also want to think about expense. So of course urinalysis would be low on the expense list, as is renal ultrasound. So think about what's best for them, especially if the doctor's going right to invasion. So cystoscopy, and I always want to know why did you choose to go with that? Most doctors too will not go to a highly invasive procedure without a good cause. Pyelonephritis, we know the etiology and pathophysiology. It is an upper UTI. It's an inflammation of the parenchyma and collecting system. Most includes the renal pelvis. Most common causes from bacteria, but it can also be from fungi, protozoa, or viruses. It can begin with colonization and infection that starts in the lower tract and goes up or ascends. Other causes could be BPH, benign prostatic hyperplasia, and it could also be from reflux or backward urine, movement of the urine. For acute pyelonephritis, know the clinical manifestations, but there typically is fever, and there will be tenderness in that CVA area. Remember the costovertebral angle where the kidneys would be, rib 12. So just a light tap and you will see that. WBCs may show up in the urine. And you might see pyuria, which is pus in the urine. You'll see more bacteria, hematuria. Again, blood is never normal. The serum CBC will show leukocytosis with a shift to the left. Remember, that's an increase in neutrophils. The young or immature bands will come. For nursing management, make sure that you collect all these subjective and objective data. Get your urine for CNS. Maintain the integrity of that culture. And then teaching for health promotion and prevention. Encourage rest. And encourage patient compliance. Encourage extra fluids. Acute pyelonephritis. Typically we start out with a broad spectrum antibiotic, and that covers everything. We wait for the culture to come back, and then they'll switch to another antibiotic once it's returned. Can also give NSAIDs. You can give something for fever. A urinary analgesic. Remember, pyridium is just an analgesic. It is not an antibiotic. And always remember that it turns the urine orange. Cipro, usually the drug of choice, but again, remember all those warnings. Achilles tendon rupture, tendinitis, rupture of the aorta in at-risk individuals, C. diff diarrhea. It can also affect the blood sugar, and there's been shown to be mental health effects. I'm going to talk soon about using a cysto, but that's usually something we go on to later. The big thing with pyelonephritis, the big complication is urosepsis, and this can cause death. This is bacteria entering the blood, and that can cause death. Chronic pyelonephritis. Oh, before I go on, let me just talk about Cipro. They should be able to put out at least 1,200 of urine per day and be able to take in fluid. Urine output's very important because this particular antibiotic can cause crystalluria. So pyelonephritis, this is from the book, and this is just a concept map of what happens. And you can see the injury and where pyelo can occur, but it can also occur from ascension. So any of those problems. Chronic pyelonephritis often progresses to kidney or chronic kidney disease or to end-stage renal disease when both kidneys are involved. Glomerular nephritis, you should remember from PN2. This is a disorder of the glomeruli, and remember that the glomeruli are microscopic blood vessels in the kidney. They have small pores through which the blood is filtered, so there's your problem. It's characterized by body tissue swelling, so generalized edema. Person also has very, very high blood pressure, and that you will see red blood cells in the urine. Often we think of this with an infection that just occurred. It's right after maybe a streptococcal infection, so always want to ask if the person had been sick recently. It can also be inherited genetic disorder or autoimmune disorders. Here is all the different things that can happen, the clinical manifestations of glomerular nephritis, and note there a lot of edema, elevated blood pressure, low-grade fever, weight gain, of course, from the edema, and all the things that would be in the urine, proteinuria, blood in the urine, decreased urine output, and painful urination. Questions, comments, fears? Remember the nephron. Nephron is just an incredible part of the body. With that said, what is the functional unit of the kidney? And you should have all answered the nephron. What does dysuria mean? Obviously that's painful urination. Dys, not good. So pain with urination. Looking at ciprofloxacin, what should the patient be advised to do, or what should they have? And the answer is C. The urine output should be at least 1,200 mLs per day. Which information from this urinalysis should be reported to the healthcare provider right away? So what are the abnormals? The abnormals, trace blood, and the WBCs 20 to 26 per high-powered field, those are too high. pH is within normal limit, and a trace protein could just mean something in their medications. A patient returns to the clinic with recurrent dysuria after being treated with trimethoprim and sulfamethiazole for 3 days. What should the nurse do? And your answer on this, you should say, let's obtain a midstream urine specimen for culture and sensitivity. Remember from the lecture that 3 days is most common for the length of antibiotic treatment for a UTI, an uncomplicated UTI. So the patient should give another culture and sensitivity to see what's going on. Tylenol would not be as effective as other over-the-counter medications. Pyridium would be more for treating dysuria. And the fluid intake should be increased to at least 1,800 mLs a day. So 1 liter isn't really enough. That answer A. Since the UTIs persisted after this treatment, the doctor will likely switch the patient to another antibiotic. When admitting a patient with acute glomerular nephritis, it is most important for the nurse to ask the patient about, and of course you would answer A, recent sore throat and fever. So as far as this is what you should know. What is a UTI? What is pyelo? And what is glomerular nephritis? We're going to look at urinary tract calculi or stones in some coming up slides. We also want to look at the nursing approach to renal assessment. Remember that kidney area is very important when you're assessing. Thank you. Here are your references.